Hello, ladies and gentlemen. My name is Dr. Ahmed Rafi Afzal. I'm a recent graduate from King Edward Medical University, and this is a short video lecture intended to help you guys on the approach to a pediatric patient and general examination. This is intended to help you orient you for your pediatrics vivas. I am an aspiring pediatrician, and this lecture has been derived from the teachings that I've learned so far in my career, and particularly evidence-based sources, including the Departments of Pediatrics, Utah Handbook for Pediatrics, and most of these I have references for. I have not included them in order to make this short, but if you guys need any material, do let me know. You can email me. So learning objectives are very plain and simple. You can read this later on, but you need to know the differences between a pediatric history and a medical history. First of all. Second, you have to realize that you are not dealing with a single patient. Your patient is a unit of the parents and the child. So the important reason why parents are considered a part of the unit when treating children is because they are the primary historian in children up to the ages of 5 years old. If your child that you are examining is less than 5 years old, do not bother with taking a history. That does not mean that you have to separate yourself from the child and do not interact with the kid at all. You need to be interacting with the kid as well, but you do not need to take any history for the children less than 5 years old. Above that, you can ask questions like, you have pain, open-ended questions that will help you elucidate on the symptoms, but you still have to consider that the parent is the major historian till we get to the teenagers sort of territory. Then we have to understand how important open-ended questions are, because the patient in your case will be most likely a panicked parent, right? And so whatever you ask them, if it is a leading question, it's going to give you a lot of wrong data. So you need to ask open-ended question and then directed open-ended question and then leading questions in the end to make sure that you have the specific details right. And then later on in your career, you can shift to a more limited focus history. But right now we're dealing with a pediatric examination, and for that you need to take a detailed history, right? And I'm gonna teach you how to do that in pediatrics. So these are the major differences between pediatric history and adult history. It's very plain and obvious. Prenatal and birth history, developmental history, social history of the family, and immunization history. I'll talk about all of these in detail later on, but you need to realize you need to memorize these. You need to have the history of at least these things out of pediatrics that are different than that from an adult history. Different how? This way. A pediatric history is similar, but it's not exactly the same thing. As I'm going to show you right now, we have the chief complaint, the presenting complaint. Why are you here? What's the major problem? And then the history of present illness, which is derived from that complaint and previous complaints, right? Past medical history. Then we get to the part which is important in pediatrics, pregnancy and birth history. This is this is very self-evident that this is supposed to be very important, right? And the following parts are for you to read and you to realize what things are important. For example, maternal health during pregnancy, right? So you need to take a prenatal history. You need to ask the mom if there was any bleeding, trauma, hypertension, fever, infectious illness, medication, drugs, alcohol, smoking, or rupture of membranes. Ideally, you would need to ask all of it. But when you're doing that in your examination, all you need to ask is an open-ended question. How was your pregnancy? Right? The next question should be, what were any issues that you faced? Right? And if that is all clear, you need to move on from that. The second and most important thing is gestational age and delivery. Before I moved on to that, you realize all of these things that I've told you, they're very specific to certain things, right? And all of these can be brought out through open-ended questions like I've told you before. Now, the gestational ages at delivery, You realize how important that is, because being a premature baby, being a baby with conditions that had a link to the pregnancy, has a huge impact on the development of the baby. And if you know what things have gone wrong, you can make a better analysis and a better diagnostic differential. The gestational age at delivery is very important. You need to know if the baby is premature or not and stop at that. And then we come to the labor and delivery. You have to, out of all of these things, they're very important in the regular history, but for the exam, you need to know the length of the labor and the type of delivery. At least these two things, right? The length of the labor is because there's going to be a lot of kids that are presenting in Pakistani OPDs with cerebral palsy, right? You're going to have those kids. And the idea that they had hypoxic ischemic encephalopathy or birth asphyxia, that's more commonly known as, you can derive a conclusion about that, all right, from the length of the labor and the type of the delivery. And the rest of the information is going to come out through open-ended questions, so don't worry about that, but make sure you ask about the labor and delivery. These are only examples, right? Neonatal period, the first month of the baby's life. You need to know the APGAR scores, ideally, but in your examination, probably not until and unless the baby has something that has to deal with the APGAR scores, like the length of the labor was 2 months, and then you have to ask, if do you know about the APGAR scores? If the patient does not know that, it's fine. You can skip that, because patients generally are not very educated, and especially in medical terminology and jargon. So it's okay if you don't calculate that. But you need to know if there was any problems, any jaundice, any birth injuries, feeding problems, and birth weight and all of those things. What you really need from all of these, you need to ask an open-ended question about each one of them. And that's about it. That will guide you later on. Do not ask about everything that I have mentioned here, because then you'll be doing all of that and not the rest of your history. Developmental history. You have to ask about the milestones, and you need to learn a couple of milestones from each age group. The easiest way to do this is to select milestones from different categories and have them arranged in a year, right? So you smile at age 6, social smile at age 6, all right. You sit without sport at 6 months, all right, that's a milestone. And further and further and further on. You do not know to have exactly an idea of the milestones in detail, but you need to know if the milestones were delayed or not. And you need to ask the important milestones, and this is something that is different from adult history, from adult medicine, but you need to know this, right? At least have a basic understanding of developmental milestones. The rest of the things, schools, behaviors, you can ask open-ended questions if you really want to go into the details, but I think for developmental history, your milestones are the most important. Now I'm going to show you a slide from the book First Aid. This is from the reproductive chapter, and it has all the milestones, and it has a way of talking about those as well. So give this a read if it feels easy for you. Primarily if you do milestones of an infant, that are enough at your level, I think. All right, so we're going to talk about feeding history. This is very important, and I'm going to do one thing. I'm going to explain each and every one of the part A, and I'm going to tie in with the clinical correlates as well. You need to know if your baby is breastfed or bottle fed, because you need to know the deficiencies that are gonna happen because of bottle feeding, which is vitamin D and iron, right? And sometimes calcium as well. If it's bottle fed, you need to know the types of formula. Why is that important? As a pediatrician, all right? It's important because if the baby is, let's suppose, in the international market, there's a milk called Lactogen Plus. If you know what lactogen plus is, it's a lactose-less formula derived from cow milk protein. I'm going into unnecessary detail, but just to give you guys a little bit of an idea. The baby is on lactogen plus. That means that the previous doctor has thought that the baby has some form of lactose intolerance. That's why the baby is on that formula. The frequency and amount is for you to have an idea if the baby is meeting his caloric demands and whether his intake is good or not. And the reasons for any changes in formula. You have a baby growing fine just with normal formula, starts developing bloating and constipation and any other issue. You change him to another formula because all of these formulas that I'm not going to teach you right now, they can be lactose free, they can be derived from soy milk, they can be derived from cow milk, they can be fortified with the vitamins and iron and all of those things. They can be hydrolyzed for milk protein enterocolitis, and they can be semi-hydrolyzed as well. So there are a lot of types of formulas, right? And if you know what type of formula is required for what type of condition, you have an idea, a decent idea about how the child has been growing up, right? Then we come to solids. Solids, when introduced, we start introducing semi-solid food by 6 months. The problems created by specific types of foods. If a kid is fructose intolerant, he has a fructose metabolic disorder, you give that kid banana mash when he's 6 months old, he's going to develop some problems. These are clinical correlations. I know this may seem a little bit of daunting, but you do not have to memorize everything that I'm teaching you right now. You just need to know that you need to take a feeding history. You need to ask about the food, the nutrition that the baby is getting, and it's very, very, very important. Now, then there's the review of systems, which is exactly similar to the adult medicine. Family history, relatively similar to adult medicine. Social history, relatively similar to adult medicine. All you need to know is if the child is what the socioeconomic status of the family is, and whether there has been any abuse or any behavioral problems or whatever, right? So these are just similar to adult history. So the most important things that we were talking about are pregnancy and birth history, developmental history, feeding history, and that is what is different with the history between pediatrics and adult medicine. Alright, now we're going to move from the history, and now we're going to see how to approach a pediatric patient. Now these are the couple of things that you need to know. You need to memorize them. These should be your muscle memory, and I'm going to teach you each and every one of them. The first one is introducing yourself. You have to introduce yourself to both the parent and the kid. You face them in their general direction, and then you introduce yourself. Do not introduce yourself twice, because that would be very foolish of you to do. Just face in their general direction and introduce yourself. The second is consent from parent and guardian. You need to take consent, whether it is a short case, whether it is a long case, whatever you're going to do, ask consent from your parent or the guardian of the kid. We do not ask consent from the kids themselves because kids are considered minors legally, so they cannot literally give consent for themselves. But in adolescent medicine, when you're dealing with teenagers, you sometimes have to ask consent because the child is growing and the child needs to realize that it itself is an entity and has a self and a being and a consciousness and whatever. But then we go to the third one, which is privacy concerns. This is very important. You're gonna have a lot of kids that are teenagers, that are early prepubescent. These kids are shy. You cannot examine them in front of everybody else. If you especially have a female child, make sure that you have a chaperone with you. Make sure that you ask for privacy. If your examiner is standing on your head and asks you to do something that has, let's say involves examining the abdomen of a female 12-year-old, let's say, you have to make sure there is privacy. You have to make sure you ask the consent from the parent and the guardian. This is very important. The fourth thing is an age appropriate approach. This is something that is natural to all of you. You're well socialized, you're doctors, you need to, right now, how you approach a 6-month old and a 15-year-old or a 12-year-old, right? So you need to make sure you approach in that manner. You cannot go jingling a Morocco, while approaching a 12-year-old, and you cannot just sternly stare a baby in the eye expecting to get any data, right? So make sure you have an age appropriate approach. Make sure on your approach you're smiling. Make sure you're welcoming. Make sure you're calm. The fifth one is a mystery. It's called a crying child. Now, there are rumor in the pediatrics department that the professor will fail you if the kid cries on your lap or if you're examining the kid, whatever it is. No, that won't happen because children cry. They have only one language, and that is crying. So, a crying child is normal child, right? The kid is gonna cry, right? So you need to know that that is not something bad. How you deal with the crying child is important. You need to know that you have to console the child. You cannot be lacking of empathy. You need to console the child, and if the child is not being consoled by you, you need to ask the mother to console the child. If a child cries on your watch in front of your professor during your short case, it's not going to be your fault. But if you do not console the child or ask the mother to console the child, then it's going to be your fault. And then if you fail, do not go outside and say that you were failed because the child cried. No, you failed because you did not know how to deal with the crying child, because nobody exactly taught you how to deal with the crying child. You console them, and if it doesn't work, you need to ask the mother to console them. All right, so do not be callous, do not be a sociopath. Just try and console the child and try to make it more calming, make yourself more calming, make your approach a little bit less intimidating, right? And also you need to have some things with you when you're doing your pediatrics viva. And I'm saying viva only because your behavior will be observed by your doctor, by your attending, by your external or internal examiners, right? And if you have like a jingle or some candy, then you can distract the child a little bit, and then there you go. If I was in a position where I was judging somebody for their approach of a pediatric person and they did that, that is an A plus, right? So do not worry about a crying child. Nobody's going to fail you, but they're going to fail you if you do not console the child and if you do not ask the mother to console the child, right? All right, how to approach a pediatric patient, and now we're talking about the physical examination, right? The first rule of physical examination in pediatrics are there are no rules of physical examination. What I mean by that, I'm going to explain at level C. But A, gather as much data as possible by observation first. When you first see your patient, you're gonna get a feeling. You're gonna know whether the patient is sick, whether the patient is very sick or the patient is normal. You can tell that by looking at the patient, sharpen your reflexes, right? So when you observe the kid, realize you see some things. What you're gonna see, for example, you're gonna see a kid with sunken eyes, right? With a sunken fontanelle. You know that that kid is dehydrated. You see a kid that is drowsy, that is difficult to arouse. You need to know that that means the kid is very sick. Whatever the problem is, you gotta have some sort of observation, and you need to report that observation. For example, there's a 15-month-old kid that you have to examine. When you go to examine the kid is drowsy and somnolent, is high, and the kid's all over the place. When you see the kid, tell your examiner that I examined a 12-month-old to 15-month-old kid, that is drowsy and somnolent and appears sick, right? All of those things. Or appears normal or whatever the condition is. So gather as much data as possible by observation first and report that observation. B. Position of the child. Where the is the kid. It's preferable to take the history while the kid is with the parent and do an exam later on, make the kid lie down and then examine the kid. It all depends whether the child is, what's the age of the child and what's the comfort level that you have developed with the child. Stay at the child's level as much as possible. This is so important, and nobody is going to teach you that in the pediatric board, because I don't know why they don't teach about approaching a pediatric patient. But you stay at the kid's level, you do not tower. What you're going to do with this is you're going to make yourself less intimidating. It's going to be easier for you to communicate with the child. It's going to be easier for the child to see you, and you will be appearing less intimidating, which will make your examination easier and better. So if you have to crouch on the ground, do that. It's fine, right? Your professor won't mind if you're making an observation doing that, if you're staying at the child's level as much as possible. For example, it's a 5-year-old kid and you need to examine the head of the kid, right? So you need to go down a little bit in order to examine the kid, right? You can't just, tower over the kid and then be measuring the head. And that is so intimidating, and your child is going to cry, and then it's going to be a problem for you because you'll not be able to get much information. That is a problem whether you're in an examination or whether you're in real life doing these things. See the order of the exam, least distressing to most distressing. The first rule of physical examination in pediatrics is that there are no rules. What means by that is the order of examination does not matter. It doesn't matter how you start, but the rule of examination is very important. Least distressing to most distressing. For example, generally when you're trying to examine the heart of the kid, the most distressing thing that's going to be is when you touch that kid with your stethoscope, because there's going to be temperature difference even if you try and warm the stethoscope, right? So when you do that, the kid's going to be a little distressed. Now if you do that beforehand, and you have to do another examination, let's say if you do this and then you have to examine percussion sounds over the left lung, you won't be able to do that because the kid's going to be crying, right? So do the percussion first, do the auscultation later, or vice versa, whatever you feel like is going to be least distressing. Because let's say the kid you're examining has tender hepatomegaly, you have to do an abdominal examination. Do not do the palpitation of that region at all. Make sure you do the other organs first. Make sure you do your auscultation, and then you do the examination that is the most distressing, which is tender hepatomegaly. It's gonna hurt a little bit, right? D. Rapport with child. You need to explain things to the child as well, right? This is important, particularly when you're dealing with the patient in ward, not as much in your examination, but you need to, talk with the child. You need to interact with the kid. Distraction is a valuable tool. Have yourself a toy. Make sure you have a jingle or something within your white coat that you can take out, and you can make the child distracted a little bit, so you can do some more examination, you can do something else, and make the most of it. Examine painful area last. Get general impression of an overall attitude. If something is going to hurt, tell them that in a calm fashion, right? So generally when you're doing a medicine examination, right, the patient that you're going to examine feels like has appendicitis, let's say. So that rebound tenderness is going to happen. It's going to be tender, it's going to be painful. What do? You tell the person that it's going to hurt a little bit, right? Especially with the patient of appendicitis, you tell them it's going to hurt, but you have to do this in order to get more data out of you. So when you tell them that it's going to hurt, you build a rapport with them, and that way the patient does not have too much of a reaction to the pain. Why don't do the same thing in kids as well? If the kid is old enough to understand you, Tell them it's gonna hurt a little bit, but it's gonna be okay, right? Just tell them it's gonna be okay and everything will be fine. Whatever language you choose to say that in, that is your determination. Physical examination, breathe, you got this. This is a breathe for you. You gotta breathe. It's just another patient, and it's gonna just take a couple of minutes for you to get used to the situation and do your job. Vitals first: heart rate, respiratory rate, blood pressure. All of these are age appropriate and different from adults. You need to realize, you need to know that that is your job to do. You have to be able to either carry a card with you in pediatrics when you're doing your rotation. If you're not doing your rotation and you're in your examination, you need to have a little bit of idea that, above 100 heart rate per minute is, pretty much normal for a neonate, right? For, a kid that's 15 years old, 150, that's a problem. Growth parameters. A, mid-upper arm circumference, the circumference of your upper arm in the middle. It is exactly what it says. It is. There's a method to do it. I would recommend that you learn it or read it from the internet. It's very easy to do. Do not worry, it's very easy. Occipitofrontal circumference, that's the head circumference, or HC is written in notes sometime. And you need to realize that you have to measure this in your general physical examination as well. You need to measure these things in your general physical examination. See, length and height. Why do I write length here? Up to the age of 2 years, you measure the length of the kid on a measuring table. After that, you measure the height on a height measuring chart, right? That those markers. It can come in form of a machine. It can be in form of a measuring tape attached to the wall. Either way, it's going to be called height. Weight you measure by. All right. So how do you measure the weight? For babies, you measure the weight on the weighing machine that is specific to babies. It has a cradle on it. You put the baby on it, and you see what the weight is. Very plain, very easy to do. For kids who can stand, you have a normal weighing machine, just like in adult medicine. You make them stand on that, and you measure the weight. What if you don't have both? Which is very likely if you're going to give your examination in King Edward Medical University. There is probably going to be a scarcity. All right, let's talk about general examination. This is very important for kids who are giving the examination in Pakistan, because the Pakistan universities mostly short case. Most common question is, do a general examination of the kid. That's at least one of the questions you're going to get in your short case, is to do a general examination. And for pediatrics, you need to know how to do a general examination, because that's your job. That's going to be your job when you are practicing pediatrician, right? So what I did, this is something that I've learned, and I'm going to try and teach you this as well. Have a pattern of examination, right? We talked about having no rules in physical examination, but we also talked about having an order of things that you have to do, from least distressing to most distressing. But if you're doing it in a short case examination, this is the perfect way to do it that I figured out so far, and I'm going to explain each and every one of it, and hopefully that will be helpful for you guys. For general examination, this is not the first step. Remember, the first step in a physical examination is to take the vitals: blood pressure, respiratory rate, heart rate. All right. Second, then you go to the physical examination part itself. What I've devised here is just a small pattern in how to do things. The clinical correlation, that is up to you. That is up to your knowledge, and that is your understanding of adult medicine, physiology, and whatever you've learned over the past 4 years. You start with the hands, and that is how I did it, and this is what I think is the most appropriate. You can change the order of these things if you want, but make sure most of these are included. You check the hands, you see both hands, you compare them with each other, and if there are any abnormalities such as polydactyly, any abnormalities as missing fingers, missing any simian creases that you're going to see in Down syndrome patients, any problem you see in the hands, right? Make sure you make an observation of that. Then you move on to the arms. You examine the arms bilaterally. Then you move on to your upper arm. This is the moment where you take your middle upper arm circumference. Alright, so measure this when you are examining their arms. After that, there's something that I've missed here, which is making sure you examine for axillary lymphadenopathy. You don't have to make sure you examine all 5 groups, but try and examine some areas as well. If your kid is older, if the kid is smaller, you don't really have to do that. You go on to the examination of the head. For the examination of the head, there are 3 to 4 things that are very important. I have illustrated all of these in the coming slides. That is for you to learn as well. But examine the fontanelles, you examine the sutures of the skull bones, and then you examine the size of the head, and that you do by measuring the occipitofrontal circumference. The occipitofrontal circumference is the head circumference, and you measure that. You have 2 out of your 4 physical parameters that you had to measure. Then you move on to the eyes. You do a basic extraocular movement examination. Even if the kid is small, you shine a flashlight, the kid is going to follow. That is reflex of the kid, right? So make sure you make an etch with your flashlight or with your finger. Make sure the kid follows it. If it is doing that, the extraocular movement is intact. Don't do anything else. Don't waste your time. Also see for scleral icterus and conjunctival pallor as well. Move on to the nose. Observe the shape of the nose. Put your thumb on the nose of the kid. Shine a flashlight directly inside the interior nares and do a general examination of the nose. You do not have to go into the details. You're just gonna make sure that you can see if there's any bleeding, if there's any severe corneal atresia. You can see by just finding a flashlight sometimes, right? So yeah, do that. Then examine the mouth. See if there are any cleft palate abnormalities. See if the mucous membranes are moist or not. See if there's any pallor or not. Observe the gums. See for rashes. See for mucosal eruptions. All of those things. Open the mouth for a second, right? Use your spatula and push the front third of the tongue interiorly down, shine a light and see the mouth. That is all you have to do. Make sure you practice that again and again and get it done within 30-15 seconds and you're good to go. Then you move on to the neck. The reason for that is to make sure you do a cervical lymphadenopathy exam as well. Make sure that the lymph nodes of the neck are okay. You move on to the thorax. It has 2 parts, hearts and lungs. For lungs, you need to see auscultate both sides at least 3 positions to be able to say that they're clear to auscultation bilaterally. Alright, now you're doing a general examination. You're not doing a heart and lung examination, so you do not need to do percussion and respiratory movements and all that. You just need to know if it is clear to auscultation bilaterally or not. Then you move on to the heart. Just find the apex beat and listen to the heart sounds. That is it. You do not have to listen to all the listening points of the heart that you already know from adult medicine. You just have to put it on the apex point and listen to the heartbeat and correlate it with the with the carotid pulse if you want to. And if you're experienced, you can already tell if S1 plus S2 is normal or not. You can even get an S3 out, but you need to do that a little bit. Then you move on to the abdomen. You do a general overlook of the abdomen. All right. Then you make sure that you do soft palpation, deep palpation, and auscultation. That is the maximum I would do for the abdomen of the kid. I would also ask them to look at the right or the left and cough, right? And also ask them to hold their breath for a little while to do the Valsalva maneuver. See if is there any umbilical hernias, or are there any inguinal hernias as well. Then you move on to the genitals. You need to do a general examination in pediatrics. Make sure you're wearing gloves. And generally in your short case, You have to, in males, you need to palpate the testes, see if they're descended. You also need to make sure that you check for the congenital hernias, congenital inguinal hernias, and patent process vaginalis. For all that, you need to do the genital examination. What you can do in your short case in Pakistan is just to observe that the genitals are normal or not. If you're not going to be doing a full examination, do at least that if a kid is less than 5 years of age. If it's more than 5 years of age, you need to ask a consent separately before doing this. So make sure the patient is well raped. Make sure that you ask the consent, at least ask the consent, because you're going to be examining a very private part of the kid's body. You need to have the consent from the parents. This is very important. Please, guys, do not miss on your ethics. 3. The last one is lower limbs. Make a general examination of the limbs as well. In this case, you can also check for the reflexes, especially the knee reflex. If you want to go into detail, there's a lot of things that you can see in the lower limbs from the musculoskeletal and central nervous system examination. But for a general examination, make sure you give them a good look. See if there is any problem that is observable to your eye. Make sure you measure the pedal pulses, and you do your Babinski sign, and that's about it. That is the general examination that I did. Right? This might seem a little bit excessive, but make sure that you have your pattern right. Make sure you have your muscle memory locked in. Repeat these again and again in your head, how you're gonna do it. And if you repeat that and visualize it again and again in your head, because of course most of you are not gonna be having access to kids to do examinations off of, so make sure that you visualize it again and again and again and again, and make sure it's part of your muscle memory. You need to measure the middle upper arm circumference and at least occipitofrontal circumference in order to do a general examination, right? And the height of the kid as well, which is something that's missing from here. But make a pattern, please, for yourself. Make a pattern, write in detail the things that you're gonna do. All right, systems. Till now we were talking about general examination. Now we're gonna talk about the systems that you can use to build your own pattern of general examination. As I've told you, you have to make sure to include all the things, but this is just for your own knowledge. You need to read this in order to have an idea of what you're looking for, because if you don't know what you're looking for, you have nothing to report. So make sure you know what you're looking for. And these slides are an addendum, right? So they're in addition to the previous lecture, but they're not the lecture itself. This is a lot of clinical knowledge, and I'm sure most of you know what we are talking about here. So make sure you just go through these slides. The slides will be attached with the video lecture as well, and make sure you learn them and you know what you're looking for. So in skins and lymphatic, for example, you need to know about the birthmark. You need to know about rashes, petechias, desquamation, pigmentation, jaundice, texture, turgor, lymph node enlargement, location, mobility, consistency, scar or injuries, especially in pattern suggestive of abuse. Yeah, that is something that pediatric is supposed to do. We don't do that much in Pakistan, but that is one of your duties as well. Let's not make sure that you include that. So skin and lymphatics, the same as the head: size and shape, fontanelle, size, tension, sutures, scalp and hair. This is something that you have to see. This is something that you have to observe. Eyes, all of these things, that is a lot, but make sure you get extraocular eye movements, and conjunctiva and sclera. These are very important, and you need to get them for your general examination. The rest of it, you can read it. You can see from your 4th year eye training whether you can do that or not. It all depends on the time. It all depends on your skill level. So make sure you just go through it. Ears, position of the ears, because that's going to tell if there's an ear infection or not. The tympanic membranes that you see on Otoscopy generally in United States, UK, when you're examining, there is a portable otoscope right there with you, but in Pakistan you're not gonna have that, so don't bother. Hearing, yes, you can do that by a cross assessment only usually. Actually, you can even make an examination of a kid about hearing in a neonate, because their reflexes and responses to loud noises, and you can figure out with observation alone if the kid can hear a little bit or not. That is something very interesting. Nose, nasal septum mucosa, sinus tenderness, discharge, all of that you can do with just one press from your thumb on the nose of the guy and shining a flashlight. That's about it. Mouth and throat, make sure you go through all of these. Neck, most important is nodes, I would say, and the presence or absence of nuchal rigidity. But for your general examination, you don't have to worry about this. Just worry about the nodes. Just make sure you have examined the nodes and have given a general overlook over the skin. Lungs and thorax, all of this is very important, but what's most important is auscultation. You need to know that you are cleared to auscultation bilaterally, measuring 3 zones in both of the lungs at least. And for your heart, you need to measure the S1 plus S2, and that is about it for your general examination. Technically, you should be able to measure all of these as well, but you won't have the time for that in your general examination, in your actual exam. Pulses, you can see the quality in upper and lower extremities and measure the difference or feel the difference between those two. That helps usually in determining problems such as aortic coarctation of aorta and all those things. But you don't have to do that. Just measure the pulse rate and see what the character of the pulse was. The kid's pretty that you're gonna have is gonna be in a stable condition. So just do the auscultation. Abdomen. This is important. This is something that you might have to do all of it. Sometimes, if you're asked to inspect the abdomen, do the inspection. Shape. Infants have a protuberant abdomen, becomes scaphied as the child matures, and then the umbilicus, the muscular integrity, all of these things that I've written here before. Integrate these into your adult medicine knowledge. This is not all of it. This is just some things that you need to know for pediatrics. Musculoskeletal, all of these things, give them a read. But what's very important to do is to check for the joints, and the hips maneuver is very important as well. Ortolani's and Barlow sign, in US and UK, but in your general examination, I would not do it right now. But you need to know what these are, just in case you're a very good student and you want to, distinction or something. Systems, neurologic systems, all of these systems, you know how to do them from your final year exams. So you know how to do these through your final year medicine exams. Alright, neurologic. Most can be accomplished through observation alone. That is true. In pediatrics, you can observe baby and figure out that most of the cranial nerves are working, but that takes skill. You are a final year graduate student, you are not required to just have a look of the kid and tell everything that's wrong with the kid. No, you can do the examinations. If the kid can follow commands, if they cannot, there are still methods of doing it. You can see them online, but there's only the most common question is to examine either the motor system or the sensory system or something like that. And in most cases, if you're going to be asked to examine the neurologic system, the kid is going to be following commands. So don't worry about it. Just know what things you have to look for. It is very similar to adult neurological exam, but the only thing that's very different is the primitive neonatal reflexes. There are 3 of them. You need to know when they come, when they go, and what they are. It's written in your textbooks as well, so make sure you go over these. And you already know that the Babinski reflex for first a couple of years is a bit different from adults, so make sure all those clinical correlative tidbits you know them. Genital urinary system, You need to see the external genitalia, especially for a general examination. But if you're asked to do it in detail, all of these things, you make sure you read those and you make sure you know what they are. So at least if you can't do it, you know what you're talking about. Right? All of these systems that I'm showing you right now, all of these systems, you have to read all of these. Make sure you know what you're talking about. So even if you don't know exactly how to do these, you will have an idea. And rectal and pelvic exams are not done routinely. Special indication: sexual assault, and genital urinary problems. For that, you may have to do them, but they're generally not done. All right, best of luck for your examination, and remember, student rights are your rights. Stand up for them. Do something that we couldn't. We couldn't make a student council. Maybe try for that. Fight for your rights. And good luck and Godspeed.